Welcome, everyone. Thank you so much for joining us for the 2021 Perinatal Substance Use Disorder Conference. I just want to let everyone know that the conference is supported by grant funds that SVSU received from the Substance Abuse and Mental Health Administration's Partnerships for Success 2020 grant. So before we get started, I just want to take care of some housekeeping items. First, if you could please sign in via the chat function. Please include your name, your credentials, and your email address. This is how we are going to be keeping attendance to provide certificates. And then the second thing is you are going to be on mute and no video through the duration of this webinar. So when it comes to time for questions and answers, because we will have a point in times when we are allowing questions and answers, we would like you to feel free to use the question and answer function, which is on the bottom of your screen to the right of the chat function. So if you can use that question and answer function instead of the chat function for questions, that would be awesome. And then we are going to be providing certificates at the completion of evaluations for the conference for your convenience, as long as you signed in the chat and you complete the appropriate evaluation for your credentials. So an email is going to be sent out following the conference that will have links and instructions included. We are offering continuing medical education credits thanks to thanks to Mid-Michigan Community Health. We are offering social work credits thanks to Saginaw Valley State University, and substance use disorder credits thanks to Mid-State Health Network. So at this point, I'm going to turn it over to Tricia Charbonneau-Ivy, who's going to provide us an update on the state of the perinatal substance use disorder issue. Tricia?
Thank you so much, Kim. I'm so happy to be here with you to talk a little bit more about the scope and issues that we're facing related to perinatal substance use disorder. So let's start out with some objectives. The three things we'd like you to take away from this presentation today are an understanding of perinatal substance use disorder, an understanding of the prevalence of neonatal abstinence syndrome, and neonatal opioid withdrawal syndrome. So we want to really start with some common language, really developing this critical component for discussing substance use disorder. What you'll come to learn throughout our time together, not only in my presentation, but throughout our conference today, is that the critical aspects of language impact all aspects of substance use disorder prevention and treatment, including the initiation and retention in treatment. For our learning environment today, we'd like to share and foster language that is in keeping with dispelling stigma and normalizing treatment, especially during pregnancy. So every effort will be made to use person-centered language and destigmatizing language. During this presentation, where specific studies are cited, language utilized might be direct quotations from those respective publications. And certainly, one of the things you'll find is that a gendered language is referenced throughout the current available body of research, and it's referenced ubiquitously in data reports related to pregnancy. So while there are both sex and gender differences and considerations in the effect of substances on the body and the treatment of substance use disorder, we will endeavor, as wherever possible, to use non-gendered language. And please recognize that gendered language used in cited research is attributable to those authors. So to start off with, we'd like to talk a little bit about common definitions. So the American Society of Addiction Medicine, or ASAM Board of Directors, adopted a revised definition of addiction in September of 2019. So you'll note that not only do we talk about addiction as treatable, a chronic medical disease that involves complex interactions among brain circuits and genetics and the environment, we also note that prevention and treatment are just as effective as in other chronic diseases. So it's a really critical component that we're normalizing addiction as being preventable and treatable. So additionally, we have a definition from the Substance Abuse and Mental Health Services Administration, or SAMHSA, on the adopted definition for recovery. So it really is a process of change, and it must be person-centered, and it comes with this broad recognition that there are many pathways to find and sustain recovery, which you'll hear a lot about later. So and that this will look so different for from person to person and family to family. So please keep these definitions in your mind throughout our time together and as we share more about substance use disorder and pregnancy. So as we know, people who are pregnant and have a substance use disorder, no matter where they are in their recovery journey, really face incredible stigma that prevents them from seeking and remaining in treatment. This is also a critical consequence to our data availability and reliability. So much of what we rely on in the realm of data for around substance use disorder is really dependent upon self-report. And if we have all of this stigma, it really does impact and prevent self-reporting by people who are pregnant, and it drives a lack of disclosure. So we rely heavily on those prevalent statistics, as you'll see throughout the presentation, and any recent reports. So keep in mind that only 6 states in the United States require public health monitoring of neonatal abstinence syndrome. The data and information that I intend to share with you today will give you some broad perspective of the challenges we face as a community in providing support for those of childbearing age, and specifically people who are pregnant and have a substance use disorder. So let's start with women in general. So substance misuse and substance use disorder is not just a concern during pregnancy, but throughout those childbearing years. So let's get a little better sense of what that prevalence looks like among women across the United States. So the National Survey on Drug Use and Health, or NSDUH survey, recently published a report in September of 2020 that was specific to women, indicating that approximately 5.6% of women 18 and older have a substance use disorder. Additionally, the NSDUH survey took a look a little deeper at those substances that were highlighted that include opioids, marijuana, and methamphetamines. So you'll notice that there was an increase from 2018 to 2019, with 13.4% of women using marijuana, women who are 12 and older using marijuana, whereas in 2019 it was 14.8%, but statistically significant. Of the 3.3% of women who have misused opioids, 98.8% of those have misused a prescription pain reliever, 5% have misused heroin, and 3.8% misused both a prescription pain reliever and heroin. Now, co-occurring disorders are common, and we need to discuss those as well, and they complicate circumstances around treatment as well. Approximately half of all those who develop an SUD also have a mental health diagnosis, and vice versa. So it's really important to consider that, the prevalence of mental health conditions among those of childbearing age as well. Approximately a quarter of women, or 24.5% of women, have had a mental illness, and 1 in 4 have a serious mental illness, with 3.6% of women having both mental illness and substance use disorder. Serious mental illness among women is rising, and we still have a high percentage of women that don't receive treatment. 40.3% of young women ages 18 to 26 and 29.7% of those 26 to 49 with serious mental illness still aren't receiving treatment. Major depressive episodes are on the rise again among women under 50 years of age. And there is a gender difference here, with 2.2 million females ages 18 to 25 experiencing major depressive episodes with severe impairment, while only 1.2 million males of the same age range experiencing this. So a similar disparity also exists among those 26 and older as well. We can't ignore the reciprocal challenges that substance use disorder and mental health concerns pose for us. Among adult women in 2019, 8.4% of those ages 18 to 25 and 4.8% of those ages 26 to 49 had a co-occurring substance use disorder and mental illness. So both age ranges are showing a slight increase over the previous year's data. Treatment for all of these conditions remain a challenge. So while 74% of folks receive treatment for one condition, nearly a little over a quarter received no treatment at all, and only 12.9% received both substance use disorder and mental illness co-occurring treatment. And that co-occurring capable treatment is so critical to appropriate outcomes for this population. So we want to talk a little bit about substance exposure in pregnancy. So by far, the most commonly used substance during pregnancy is nicotine, typically through cigarettes or vaping. And you'll see that 15% of pregnant people use nicotine. Additionally, approximately 1 in 9 women reported drinking alcohol in the past 30 days. Approximately 7% of pregnant people use marijuana. Of those that have indicated that they have used marijuana during pregnancy, 50% continue to use throughout their pregnancy. A 2020 report published in the American Journal of Preventive Medicine found that both current alcohol use and binge drinking among pregnant women ages 18 to 44 years in the United States increased slightly from 2011 to 2018. Current drinking, meaning having had at least one drink of any alcoholic beverage in the last 30 days, increased from 9.2% in 2011 to 11.3% in 2018. Binge drinking, additionally, has also increased, having 4 or more drinks on an occasion during the past 30 days increased from 2.5% to 4% in that same time period. And this data for the report came from the CDC's Behavioral Risk Factor Surveillance System. So additionally, opioids are certainly a point of discussion here and has grown as a point of discussion around substance use during pregnancy. So additionally, among women who reported alcohol use, approximately 40% also reported other current use of one or more substances. The CDC indicates that self-reported data shows in 2019, about 7% of women reported using prescription opioid pain relievers during pregnancy. And of those, 1 in 5 reported misusing prescription opioids. And that's defined as obtaining them from a non-healthcare source or using them for a reason other than to relieve pain. Additionally, 25% of pregnant people were prescribed an opioid during their pregnancy. And maternal opioid use has quadrupled since 2000. So what are the impacts of this? So according to the American Society of Addiction Medicine, or ASAM, women with substance use disorder have high rates of unmet reproductive health needs. This is a critical issue because this doesn't just affect mom, but it also affects the fetus. So while 50% of pregnancies in the United States are unplanned, the rate is estimated to be as high as 80% among those with substance use disorder. Short intervals between pregnancies may also be disruptive to treatment. And additionally, receiving inadequate substance use disorder treatment is associated with poor adherence to prenatal care, attention to maternal nutrition, worsening of co-occurring psychiatric illnesses. This all sounds like a perfect storm, right? So not only is it just that, but women with substance use disorder are even more likely to have co-occurring psychiatric illness and often face a whole host of other psychosocial stressors. Those can include high rates of exposure to adverse childhood experiences, potentially traumatic childhood events, including sexual and or physical abuse, and are more likely to be in a current or recent violent relationship. So substance-affected homes and households and environments can also complicate or contribute to poor health and compromised well-being for the pregnant and postpartum person and their children. Some pregnant women with substance use disorders experience housing and food insecurity for themselves, as well as their children in their care. So Child Protective Services involvement might come along and need to occur, but can often disrupt important maternal attachment, especially with their newborn child. So unfortunately, there's a whole host of stigma and discrimination that happens around substance use disorder in pregnancy, and that is from not only the public at large, but healthcare providers. Recently, more public concern around preventing fetal harm has really resulted in some states implementing punitive measures against pregnant and postpartum women. And what we understand is that punishing pregnant women really impedes that proper medical care, the uptake of an initiation of treatment, and the retention in treatment, as well as the promotion of public health. So we recognize also that postpartum depression is more common among those with substance use disorder compared to those without. And the first year after delivery is so important, but it's very stressful for the person who's delivered. With stress being a known relapse factor, folks are at increased risk of relapse and overdose at that time. After delivery, the previous close contacts with their prenatal care providers cease, and SUD treatment providers may be the only provider of continuity in these circumstances and during this critical time. The highest risk of overdose is 7 to 12 months postpartum, and those on treatment have lower risk of overdose than those not on treatment. Despite all of these challenges, keep in mind, pregnancy presents this incredible opportunity to, and may even serve as a catalyst to adapt or change lifestyle behaviors to optimize health for the person who's pregnant and for the baby. Public awareness efforts of substance use related risks during pregnancy encourage and really help women to quit or cut down substance use at this time. Motivation to change during pregnancy is really inherent. So we want to take a look at pregnancy and substance use disorder and how prevalent that is. So approximately 5% of all people who are pregnant have a substance use disorder. 18.1% of pregnant women reporting marijuana use in the past year met criteria for marijuana misuse, dependence, or both. We also know that the number of women with opioid-related diagnoses increased by 131% between 2010 and 2017. Opioid use disorder is also associated with a 4.6-fold increase in maternal death during hospitalization. Vital records studies that have been completed by Schiff et al., published in 2018 in the Obstetrics and Gynecology journal, indicated that opioid overdose risk tends to be highest earlier in pregnancy, as we mentioned, with the lowest risk occurring in the third trimester, with 3.3 per 100,000 deaths, but that risk becomes highest postpartum, 7 to 12 months after delivery, with a rate of 12.3 per 100,000. Of note is that overdose death rates for those in medication for addiction treatment therapy were lower than those for not receiving pharmacotherapy-based treatment. And it was found to be statistically significant at the 4 to 6 month range, with a rate of 1.3 per 100,000 for those who are on MAT treatment versus 10.7 per 100,000 for those not on pharmacotherapy for their opioid use disorder. So as we know, substance use has an impact not only on the pregnant person, but on the fetus as well. So let's explore a little bit about those impacts. So we know that the majority of data that is available is around fetal outcomes related to nicotine and alcohol. We do not know exactly how many people have fetal alcohol spectrum disorders, but several different approaches have been used to estimate how many persons are living with FASDs in the population. And FASDs continue to include several diagnoses related to exposure of the baby to alcohol during pregnancy. And then more specifically, fetal alcohol syndrome is that most involved diagnosis and used to represent several physical and developmental abnormalities that are present. So the CDC has used medical and other records to perform studies that have identified about 0.2 to 1.5 infants with fetal alcohol syndrome for every 1,000 live births in the United States and in certain areas of the United States. The most recent CDC study analyzed medical and other records and found that FAS was in 0.3 out of 1,000 children from 7 to 9 years of age. And additionally, it's been indicated that potentially 1 to 5% of the population of school-age children in the United States and some Western European countries have FASDs. So it's important to note also the cost to the systemic cost, not just the interpersonal or micro level costs, but an individual's lifetime cost for treatment of FAS in 2002 was about $2 million. And the expense to the United States annually is well over $4 billion. So let's talk a little bit about neonatal abstinence syndrome and neonatal opioid withdrawal syndrome. So currently we have no comprehensive national surveillance system for NAS and NOWs. 6 states have legal or policy requirements related to NAS and NOWs reporting. Now, the Michigan Department of Health and Human Services Office of Recovery-Oriented Systems of Care has published a report on neonatal abstinence syndrome, citing data from 2014 to 2016, obtained from various hospitalization records. In 2019, additionally, the Council of State and Tribal Territorial Epidemiologists released a position statement providing standardized case definitions for neonatal abstinence syndrome to improve clinical record documentation and provider reporting as use and application of diagnostic criteria and those respective codes have varied from state to state. And creating this consistency and continuity in the documentation helps us to better be able to compare apples to apples as we're developing good surveillance systems. And it will help us to improve our data collection and reporting. It'll contribute to better understanding of the incidence, exposures, and the burden of the disease and the health impact that in utero exposures may have on neonates. So finally, we want to talk a little bit about this intersection of virality, substance use disorder, neonatal abstinence syndrome, and NOWS. In rural Michigan, there is a significantly higher rate of NAS births. Our northern rural communities, as you can see on the map before you, have really faced incredibly higher rates of neonatal abstinence syndrome. Additionally, they faced health professional shortage areas for primary care and mental health providers. Many communities still do not have even a single buprenorphine prescriber, let alone one to provide treatment for persons who are pregnant. This leaves people traveling great distances for treatment or simply going without the critical care that they need. In 2014, for instance, in the urban Detroit area, the rate of NAS births was 5.1, while it was 21.5 in rural northern Michigan. The NAS data for rural communities is really reflective of that intersection of these significant psychosocial challenges and the lack of available treatment resources for substance use disorder, especially in pregnancy. So as we develop this more robust surveillance system, it really allows us to deepen our understanding of the impact of substance use on our community, empowering us to better develop these responsive policies that support the compassionate, timely, and effective delivery of treatment to people who are pregnant and their children. So thank you very much. You'll see across the next slides are my references, which you'll receive in your mailer. And I want to turn it over to Kimberly Martini-Toth, who's going to speak to us a little bit about the types of interventions that are happening in our communities through specialized projects to get at these challenges. Kim?
Thank you so much, Tricia. Tricia said, I am going to go ahead and talk a little bit about the My Babies project overview. It is funded through a 5-year grant from the SAMHSA Partnerships for Success grant. So with the grant, we are going to be working with 6 rural counties in Michigan: Aranac, Bay, Gladwin, Iosco, Ogama, Ascota counties. And we chose these 6 counties because their rates of neonatal abstinence syndrome and neonatal opioid withdrawal syndrome, as well as babies born substance exposed, is 2 to 3 times greater than that of the state level, the state rates. And they also have a shortage of mental health and substance use disorder providers in those counties. The shortage of providers oftentimes makes it difficult for people of childbearing age who are pregnant to get the help that they need and that they may want in a timely fashion. So in those counties, we will be looking to work with private and public organizations who serve this population. So our overall goal of the grant is to decrease the number of babies born with NOWS, or who are substance exposed. And we'll be doing that through several different avenues. So one way in which we plan to do that is we plan to identify patients who are living with risky substance use or with a substance use disorder by completing a process called SBIRT. So SBIRT stands for screening, brief intervention, and referral to treatment. And to do this part of our grant, we're going to be working with our partners to use a program that is called High Tech, High Touch. This program is online based and can be completed through any handheld device, laptop, desktop, computer, etc. So all the patient will need is a web browser, an internet, or cell service to be able to use it. The product begins by going through the screening process, and we will be screening for depression, substance use, as well as tobacco use. And then after all the screening process is completed, the program uses what we call motivational interviewing to lead into a brief intervention, and if it's needed, if the screening is deemed positive. So then once the brief intervention is completed, if there is a need for treatment, the program will then provide the patient who completed it with available resources to either enroll in a program or to contact in order to get into services. So if a patient needs to be referred to treatment, we've already identified these areas as having provider shortages. So patients could end up waiting months for services. And we all know that it's really important to get people who are pregnant into services as soon as possible in an effort to help protect not only them, but the fetus as well. And so in an effort to help decrease the treatment disparity in our partner counties, we're going to be trying out a program called Computer-Based Treatment for Cognitive Behavioral Therapy, or CBT for CBT. So this program uses cognitive behavioral therapy to help patients reduce or stop substance misuse or abuse. And studies using this product have shown that patients who use it have the same, if not better, results than in-person CBT. Another way in which we are looking to address it is SVSU started Project ECHO, which stands for Extensions for Community Health Outcomes. And it's an evidence-based telementoring continuing education model. And we started it in 2018. It's a hub and spoke model of education, and it brings together interprofessional hub team of experts and spokes comprised of a continuum of healthcare providers, communities across Michigan and the United States that come together in an all teach, all learn environment. So in June of 2021, we successfully offered our first perinatal substance use disorder ECHO session. And our perinatal substance use disorder panel offers the expertise of an addictionologist, a psychiatric mental health nurse practitioner, a social worker who specializes in treating substance use disorder in pregnancy, as well as a peer recovery coach with lived experience with substance use disorder in pregnancy, and a pharmacist. And the session each of our sessions feature a didactic presentation, which is focused on substance use disorder in pregnancy, as well as an interactive case presentation that offers participants the opportunity to bring challenging cases to the team and their peers for some timely support and some expert guidance on the patient and treatment for the patient. All cases are de-identified, and everyone participates by asking questions and providing impressions and recommendations in keeping with the all teach, all learn model. And you can go to the website at the bottom, svsu.edu/ECHO, for more information on the Perinatal Substance Use Disorder Project ECHO, as well as to register for it. So some of the other things that we're going to be doing is with the grant, we will be hosting a yearly perinatal conference. So this is our first year, and we'll be holding them every year through 2025. We will also be providing expert education and training to our partner organizations. Each partner organization that we work with will be receiving online expert education, followed up by simulations to practice the skills that they learned through the training. And then lastly, we will be encouraging providers in these areas to go through data waiver training so that they are able to provide medications for addiction treatment to people, an effort to decrease the treatment disparity for these rural counties. So that is all regarding the My Babies project. And now I'd like to move on to our provider patient panel. So as you will see, the objectives of our provider patient panel are to understand challenges that people who are pregnant and living with substance use disorder face, as well as understand ways to engage pregnant people in treatment for substance use disorder. Tricia Charbonneau-Ivy is going to be our facilitator for the provider patient panel. So I would like to turn it over to her to go ahead and start the panel. And I should say, this panel, we are using what we call an immersion scene. And so you are going to see kind of, it's not going to look normal. You won't see the screen. So they're sitting in front of, maybe not. Oh, there we go. So they're sitting in front of a fireplace. So Tricia, go ahead.
Thank you so much. Thank you, Dr. Maroney and Tricia. Thank you, Kim. Thank you all for your patience. It looks like it's taking a second to put you all in the fireside chat mode, but we thought it would make it a little more cozy to do it this way. Hopefully it'll convert over for us in a second, but if we have issues, we'll convert back to the gallery view. But essentially what we're here to do today is to talk with Dr. Maroney and Tricia about their experiences as a provider and patient respectively. So we'll just facilitate through a series of questions. And then if any of you have questions, you're welcome to use the question and answer function at the bottom that Kim referenced earlier so that we can ask those of Dr. Maroney and Tricia. So let's get started. I'm going to start with you, Dr. Maroney. Can you tell us a little bit about yourself professionally and how long have you been treating pregnant patients with substance use disorder?
My number one faux pas is that I always forget to unmute. And we can see that across the spectrum of my involvement in teaching. Substance use disorder treatment in pregnant patients is something that theoretically I started like 25, 30 years ago when I tried to get to medical school. And it was very interesting. It was in my interview I discussed to show you how rigid and sometimes Neanderthal-like traditional medicine is. I was asked, what really excites you? What do you want to do? And I talked about treating addiction, which would, at that time, would require only a psychiatry residency, and reaching out to a pregnant patient with addiction. And that would only mean training in OB. And I was told in my interview that that's ridiculous. You would never want to do. Why would you take those two things and put them together? It just made no sense. And I was scoffed. And here today, that's what I do. So the lesson there is traditional medicine was way too rigid. And eventually, evolution and progress lead us to what we really need, the tools of the people and the education. I left a career as an engineer in a pharmaceutical company in 1993, 94, and I'd been there since 95. While I was an engineer, I earned a master's from the University of Missouri School of Pharmacy in Kansas City in pharmacology and toxicology because I just love chemicals, especially new ones. And that's what drove me into addiction. When I finished, I noticed that I was just a medical student starting residency and internship. And like all residents and interns, you work late night shifts and you admit a lot of people and it's kind of dirty. And they say, everybody does this, you have to do it. But I developed a bond to a gentleman. It wasn't a pregnant woman at that time. It was a gentleman. And what he taught me was that no matter what we did in traditional medicine, from what I learned from medical school, is that we had no answers for him. Now it was 94, 95, 96. That was pre-Suboxone. It was pre-Vivitrol. And naltrexone tablets really weren't being used at that time. And the only thing we had was methadone clinics. And today we probably have 1,900 methadone clinics. In America at that time, we probably only had 300 or 400. Nobody knew how to refer. And when he came in and he overdosed over and over, time and time, we admitted him into internal medicine and it just didn't work. He wasn't getting better. I wanted to learn what we really needed to do. When I began treating at a private level locally in the Great Lakes area, the Huron and Michigan, I began to see pregnant patients who came to me that were in treatment and became pregnant. And I wondered how difficult this was and what was my liability and what was the standard of care. And that was all back around 2001, 2002, 2003, 2004. And I just really didn't understand. So I looked to train in that area. And what was the training tool and the standard were the methadone guidelines, because methadone had been there for 20 years. But methadone wasn't going to reach the number of people that needed help. And that's why I trained in office-based opioid management, OBOT, so that I could prescribe buprenorphine. And from there on, you kind of have to say, here's the methadone rules, and here's a problem with buprenorphine patients, has no answer. How do you synthesize it? And that's what I've been doing for about 17 years. Every time you come across a problem with medication-assisted treatment in prescribing buprenorphine, and you don't know what to do, you look back at the federal methadone laws, and they've been there to teach us since the late 70s. So that's how I got into this, and I've been doing it for about 17 years. And we've served probably 16 or 1700 couplets in the 16 or 17 years we've been doing this.
Thank you. Thank you for that. Tricia, can you introduce yourself and tell us a little bit about your recovery journey?
Hi, good afternoon. I'm a grateful believer in long-term recovery. My name is Trish. I am the Bay County Recovery Access Coordinator for Peer 360. I am a peer recovery coach, and today I sit before you with 5.5 years of recovery, of time spent away, abstinence of substances. I'm trying to find a way. I'm still working on my stigma, reducing my stigma as well. My recovery journey has been a roller coaster. Coming into recovery, putting the drugs down, getting off the drugs was just the very beginning. And I thought, pre-recovery, I thought that was the goal. Putting down the drugs was just the first part. I was left with all of this mental trauma and anguish of a lifestyle that was lived out in active illness. I remember my thoughts being so loud in my head. They were so uncontrollable. It was like my brain was misfiring. I did not know how to live and act normal or according to society standards. My first year in recovery, I did not have a support system. I was only abstinent from drugs, from substances. I worked a lot. I tried to stay busy, tried to keep my mind busy and occupied. That worked for me for my first year. However, I was still white knuckling it. When I would have cravings, I would just distract myself. I didn't have the tools in place to know exactly what to do with myself. I was out of state as well. I moved out of state to get off of drugs, and I moved in with my father. And my father ended up passing away when I was there for. I got a good 6 months with him, and he helped me to get off the drugs. Anyway, so my first year in recovery was without drugs. I ended up moving here back to Michigan, and I was introduced to recovery pathway. I'm so sorry. I was introduced to a counseling center, and counseling coupled with recovery therapy and MAT has significantly helped me. It has changed my life. I learned a lot of tools in counseling. They were mentioned previously. CBT, cognitive behavioral therapy, has helped teach me so many tools, how to live in the moment as well. My thinking distortions, the way that I perceive life, my perception of life, and how skewed it was from baseline or society standard. My recovery today is amazing. Today, I am a good mother. I have custody of 2 beautiful children that I have had since I've been in recovery. I am an honest person. I contribute to society today. I'm responsible. I can pass my drug screens today, every single one of them with flying colors. My recovery truly has been something extremely beautiful, and I am grateful, extremely grateful for it.
Thank you so much, Tricia. So, doctor, can you tell me what challenges you've experienced in patients accessing treatment from obstetricians and gynecologists while in active use or while undergoing treatment?
It's probably about 3 or 4 different barriers, and I have to break it down. The first one is absolutely no care. People get absolutely no care. What the barrier is, there is no care, and there's probably 2 reasons. So it's like the first one, and it's 1A and 1B. And 1A is that there's care somewhere, but there's no transportation. It could be electronic, but there's no media. There's no access. Transportation electronically or physically, picking Trish up, putting her in a car and getting her to some place. That's what's a big part of it. And the other part is one of the dilemmas that the My Babies grant is trying to look at and measure and then reverse or reduce is no care available per county, whatever that comes out to be. So that's 1. 2 is there are care centers or care teams or departments of care, but they have absolutely no idea what they're doing. They need training so that you do have providers someplace, but they don't know what to do. Number 3 would be care from a provider who has had some kind of training or has read something or has seen something, has been online, and they think they're informed, but they're using old guidelines. They're using less than evidence-based information. And the 4th kind of care is what we try to get past the barriers to is matched, experienced, properly trained, evidence-based care that's matched. What's needed and what does that provider have? Those are our 4 issues.
Thank you so much, Dr. Maroney. Tricia, can you tell us about your experience with seeking treatment from an obstetrician while you were pregnant?
Absolutely. Okay, so I have a total of 5 children. 3 of my children are from when I was actively using. I lost my rights to them. I do not have custody of them. My 4th and 5th child, I've had the 2 of them since I've been in recovery. So pre-recovery, seeking help from an OB, I put it off for a while. And I put it off because I knew that when I got in there, I would not be able to pass a drug screen. I knew that if I were to go in there and if I were to go in there and give them a poor urine screen, that they were going to call CPS on me and I would have CPS in my life. So that was a barrier. My first pregnancy, I was on Vicodin and I was actually being prescribed Vicodin by a provider. I was being prescribed it throughout my entire pregnancy. I was not honest with my provider about my pregnancy. All I had to do was call my provider over the phone. I never had to come in to see her. And I did not know, I was 17 years old at the time. I did not know the effects that this opioid would have on my child. So seeking OB help the first time around, I was naive, and I had a lot of trauma that first time around. So I was walking in blindly to an OB. I didn't know what to expect, but I quickly found out. So for pregnancies 2 and 3, I was guarded. Seeking help with OBGYN now, it's totally different. I can pass a drug screen today. However, I do have to say, if I'm being totally honest, with my first pregnancy being in recovery, so baby number 4, I was on Vivitrol, which is a medicated assisted treatment. I was on the Vivitrol shot, and I ended up getting pregnant. I went to my OBGYN in my county, and they did not seem to know anything about Vivitrol. So there was no there was no statistics, there was no facts, there was no research or evidence to say that it would be safe for myself and my baby. So the OBGYN at the time recommended me to a methadone clinic. I was mixed emotioned, okay, because I have had children being on methadone in the past, and methadone, it served its purpose to get me off of using drugs intravenously, and it was harm reductive. However, the withdrawals, seeing my babies in withdrawal was just awful. So, and I know how hard it was for me to get off methadone. So when she kept trying to pursue me in that direction, it was extremely defeated. It felt like, okay, I did all of this just to get told to go back and do it again. So I stood my ground, and I ended up teaming up with an awesome doctor who encouraged my decision. And I went forth with that pregnancy on Vivitrol, and I gave birth to a beautiful baby. I had an awesome pregnancy. I did have gestational diabetes during that pregnancy, but I gave birth to a very healthy baby. Baby had absolutely no withdrawals. And I'm sorry, I'm getting a little off track. What was the original question?
Yeah, I think you hit it on the mark, because you really did tell us about what your experience was while seeking treatment, and you touched on what kinds of things prevented you from seeking treatment from an OB, and what your fears were when you were pregnant, and then some of the stigma that you faced. Did you find there was anything that was encouraging or supportive behavior toward your treatment? I heard you say you had an awesome provider that helped to encourage you through that. Was there anything else that contributed to that?
Yes, being able to come forth and be open and honest about my past of active illness and about me being in recovery, I think it was a paradigm shift for my point of view on the OBGYN, as well as for their point of view on me, because they knew that the standard of care was going to be different for me versus somebody who has never been in active illness, that I was going to require different things. So their knowledge and their understanding of where I'm at, what stages of change that I was in my recovery, I think it helped significantly. So knowledge from the doctors about recovery played a major role in it.
Thank you. It's very helpful. Dr. Maroney, can you speak to
Can I interject for just
please?
less than a minute and piggyback? I like to piggyback on people like this. What Tricia experienced is existing and is rampant. Every single Vivitrol patient I have, we'll give 600 Vivitrol shots this year. Every single one, if it's a patient who becomes a pregnant patient, has been taken away from me by the OB and reassigned to a methadone clinic. So we need the knowledge. There's something that Tricia said that nobody can ever take away that is pinnacle. She gave birth to a drug-free baby in a setting where stigma and punishment is attached to drug treatment. You cannot put value on when she gave a birth to a drug-free baby. Nobody understands that. It's like, what do I need to do now? I need to do something now. What every single one of those OBs needed to do was to pick up the phone and call her doctor. And it's not happening. So we don't have enough of the information, which is what you said in the very beginning when you were lecturing, Tricia, is that we just don't have enough information about this. And people are not looking for the standard and the guidelines to contribute. They're misinformed, or they have no idea, or they're using old guidelines. That's it. Trish, I really admire you. You're doing a great job.
Thank you. And thank you for having the courage to come and share your story. We're so grateful, and we're learning so much from that. I wanted to, in follow-up, Dr. Maroney, this is actually, you helped me segue actually. So what other ways can providers effectively coordinate care? You spoke to pick up that phone and call that provider with both their patients with SUD and other providers. So how can doctors and other providers do that? most effectively?
I think it's really important to look at the substance use disorder world and treatment providers. And, we're really not accepted into family medicine or, internal medicine. You have to begin to start including, our therapists and our doctors, because this is a sequential journey over time. And we want everybody to consider the substance use disorder treatment, the experiences in labor and delivery, the pain management questions, which they call you at the last minute and say, oh, what are we going to do? What are we going to do? It's like, no, think about that when she's 3 months pregnant. And then the follow-up after delivery, especially for the substance use disorder treatment. A lot of people, I have had a couple doctors call me and say, well, this is your Suboxone patient, and we gave IV Dilaudid after cesarean, and she's not having any pain control. No kidding. But you did that when she's in recovery, and I'm having a hard time helping you fix it now. We have ideas, we have plans, and having the anesthesiologist talk to us before they deliver, coordinated care, integrated care. That's the biggest thing that providers in the medical world, looking back to substance use disorder, that greater integration, we're still treated like it's all silos. Everybody's in a silo.
Mm-hmm. And I think you've highlighted so many instances where that collaborative approach is really critical for positive patient experience and outcomes. So, Tricia, let me ask you a little bit about what kind of, we've been speaking to education as it relates to providers, but what kind of family education did you receive or would have been helpful during your pregnancy for your greater support system? And so family for this purpose means, not only those folks that are related to you, but, those folks that you choose to have in your life as support people. What education was helpful or would have been?
So what was extremely helpful was having a recovery community to turn to, having a counselor, having a doctor who just knew stuff, having those important people in my life to turn to for when I needed support. What was unhelpful, or I guess what could have been better, was knowing the plan from the hospital's perspective. It would have been nice to know the plan of what's going to happen after I have my baby. What ended up happening with my fourth pregnancy when I was on the Vivitrol shot, in my head, because I'm not on any narcotics and because I can pass a drug screen, I'm going to be able to take my baby home immediately. And I was so proud because I worked so hard to be able to do this. I stopped smoking cigarettes. So I stopped drinking coffee. I stopped drinking pop. So I was walking a tightrope by choice. So I kind of felt like I should deserve a pat on the back and be able to take my child home. That did not happen. When I got to the hospital, they were preparing me for a C-section. And the nurse was asking me questions and checking me in. And she nonchalantly, we were just having a conversation. And she said, so are your other children at home looking forward to this child? And I was like, well, I said, well, I don't have custody of them. They're placed elsewhere. That alone, she called CPS on me while I was at the hospital. And so something about the way that I said it, she ended up calling CPS. So CPS came a couple of times before I had any pain management. After my C-section, as soon as they wheeled me back I was in excruciating amount of pain. CPS came in a couple of times. They got involved. It was disappointing. They ended up keeping myself and my child there for about 5 days. And I didn't feel like I was ever going to be able to go home. I thought they were going to keep me there forever. I thought that they were devising a plan to keep my child away from me. So it was reliving that trauma all over again. When I had my most recent child, my baby, she just turned 1 the other day, by the way. When I had her, I was on Zubsolv. And let me back up. So I was on Vivitrol. I gave birth to baby number 4. I was on Vivitrol. I ended up getting on Zubsolv for pain management due to my C-section. And I was taking my time titrating off of that over a period of time, and got pregnant again. My husband and I got pregnant with our second child, and she's the one that just turned 1. So when I got pregnant, I was on a low dose of Zubsolv. And I went through this entire pregnancy, obviously still in recovery, gave birth to my baby, and this baby also had no withdrawals. However, the baby's sugar was low. They had a hard time keeping my baby's sugar up. So they took my baby to NICU. And so being separated from her automatically was a trigger. It was traumatic because once again, in my head, I thought they're devising a plan to keep my baby away from me. And I was so scared. The irony is I'm a recovery coach, and I fight against stigma, and I fight and I advocate for people. It was so challenging to be able to advocate for myself and the pain that I was feeling. I don't know. Honestly, I don't know if it was pride or fear of how they're going to look at me. I was so scared to reach out and ask for help. I was feeling an immense amount of pain. And I was just scared of how they were going to look at me. Were they going to keep me away from my baby longer if what they gave me wasn't good enough? Because I was accepting all non-narcotic treatment. I did not want anything that had any bit of narcotic in it. But once again, when it wasn't working, I was scared that they were going to assume that I was drug seeking based on it not helping my pain. So what would have made it easier was knowing a plan ahead of time, because for myself, being in recovery, routine for me is key. So knowing ahead of time exactly what's going to happen and knowing how to prepare myself for that, so that I'm not being caught out of left field and then I'm placed in a situation where I don't know how to react. And then my mind just starts jumping to worries. And the next thing you know, I'm in a situation to where I'm having cravings, and it starts unrolling from there. So having a routine set up in place from the hospital's point of view. My doctor did an amazing job. He kept in contact with me throughout my whole pregnancy. I saw him regularly. He told me exactly what was going to happen with my medication. This is how we were going to do it. So my plan with him was legit. It was awesome. With the hospital, not so much. So if the hospitals could get on board with better SUD care, I think it would be paramount in perinatal SUD.
Thank you. Thank you so much. Doctor, can you speak to what interactions are like with labor and delivery? So, Tricia, I'm sure Tricia's experience isn't an anomaly. So what do those interactions look like, and how do you as an addictionologist interact with the OB-GYN and labor and delivery and so on?
Well, for a better part of the last decade, I've been close to an OB department that has my privileges at their hospital. So those interactions are textbook and positive, and other hospitals, whether it's a cultural thing, instead of reaching out to somebody that may be recognized expert in their field in the community, they appoint somebody in their own hospital as this is our SUD expert, and that doesn't always work out really well. That also happens at universities, that instead of reaching out to somebody with 20 years experience, they'll pull somebody who's never done a Suboxone prescription and say, well, you're our new SUD guy and you're internal medicine. So you kind of have to break through that barrier politely and not hurt any feelings. I have a problem with that. It happens a lot. What we see, though, is anesthesia needs to know what your patient's getting, because anybody can go from a vaginal delivery to a C-section in 5 minutes, bam, and it changes everything. So you have to be comfortable, and I've talked to anesthesiologists before and after, and then this is how this also relates, is that anesthesia remembers that you do the pregnant girls in C-section, but now they have men and women on medication-assisted treatment that are having gallbladders. And it's the same problem. Well, that's because treatment is expanding across all age groups and specialties. All sorts of people in treatment are getting shoulder replacements and valve replacements and gallbladder stuff. And it's catching up at the hospital to go, oh, we don't know what to do with this stuff. OB is, at the very least, leading the edge. It's where the decisions are being made to teach everybody else. And then one of the things that Tricia mentioned in custody because of previous pregnancies not having the same resources that she currently had when she was healthy and she had a good relationship. Well, those labor and delivery staff need to have the education that it's not just about stigma language, it's this patient here and now. And we try not to treat things from 10 years ago when we see people today. We try not to do the what ifs. It's this patient here and now. When she walked into her hospital and she produced an appropriate urine drug screen, that's really what her intake should have recorded. And the triggers for Child Protective Services need to have a filter that if they have any question and there's a provider attached to her care, that CPS needs to go through that provider. And then we have the pain management coming out. We understand that some medication is going to block what the hospital traditionally uses. Well, your addictionologist knows how to get around that. So we want to involve them early. And then the follow-up, when she's released, what is the policy? The standard policy is if you gain weight and you gain blood volume, you may increase doses of methadone and buprenorphine in later stages of pregnancy, because pregnant patients go into withdrawal because their pharmacokinetics change. They don't do anything wrong. It's because increased volume and water weight gains. Well, you would explain to the patient that we're going to return to a pre-pregnancy dose and a pre-pregnancy level and pre-pregnancy evaluations. That's really important because they may interpret you giving a lower dose without an explanation as a punishment. But you go from somebody who may have been 185, 195 pounds back down to somebody who's 140 or 150 pounds. You have a significant milligram per kilogram difference that you don't want to snow the current patient, and you want them to be functional so that you do make those changes. So those are some of the direct effects in labor and delivery: communication, education, filtering CPS so that CPS doesn't start a storm that has absolutely no bearing, no precedence to maintain, and then the follow-up care with pain management and then adjustments to substance use disorder. That's what we need to work through. Prenatal versus perinatal. Prenatal, you want to explain it as early as you can.
Okay. So can you speak to the types of postpartum care? You kind of alluded to the adjustments based on weight and milligrams per kilogram and so on. But are there other adjustments that need to be considered for postpartum care?
A really sharp patient who's experienced some kind of postpartum depression will speak out to you right away and say, in my last 2 pregnancies, I had postpartum depression. So let's get on board early so I don't go home and struggle with this. Listen to your patient. That's very important. That patient went through postpartum depression twice, or they know what antidepressant doesn't work or does work. And maybe you can start that in the hospital. And if it was a postpartum depression, well, then that they didn't get it later and they were able to get off their medicine. And it was a window of behavioral modification. that you have to be aware of. So that is the secondary thing. And sometimes Trisha had a partner in a healthy relationship. If you have a pregnant patient that delivers and you don't know what kind of resources you're sending them home to, well, that may not be healthy. And like we've said, sometimes hostile and unhealthy relationships are not things you want to find out by accident. You really have to delve into a really good biopsychosocial on your pregnant patient to see, from my standpoint, in violence and abuse against women, pregnancy is number one time where a partner can become violent and abusive in a pregnancy situation. So you have to know that too. Those healthy relationships to be going back to: is it your mother? Is it your sister? Is it a partner? Are you living with another girl? And is she your best friend? You share living situation. Just see how healthy it is, and the cues, and then the postpartum depression. Those are two really big important things.
Thank you. Thank you so much for that. So Trisha, we talked already a little bit about the different types of preparation you would have liked to have so that you would have known what to expect. In any of your more recent or previous pregnancies, would you have wanted different preparation or information on what to expect for your baby's treatment, not just your treatment, but your baby's own treatment, and what that would be after delivery?
Absolutely. And it's funny that you asked that question, because not in any of my 5 pregnancies was that ever discussed. It wasn't discussed. I was not included in it. I remember coming down or going up to the NICU. I think it was on my 3rd child, and they were discussing giving my baby benzodiazepine because I was on benzodiazepine. My 3rd pregnancy, I was using methadone and all types of other drugs. They were discussing giving my baby benzodiazepine to help with withdrawal. And I'm standing right there, and they didn't ask my opinion about it. And I know that I'm addicted to it, and I know how I couldn't get off of it. And I think I threw a fit about it. That's something that I did not want my child on. So yeah, it was kind of on a case-by-case basis, or for me, a child-by-child basis. I did not know ahead of time. They never discussed with me, okay, well, this is going to be, if when you have your child, this is what we're going to do. This is what's going to help. That didn't happen. Now I did know when their doctor's appointments were. I would take them to their doctor's appointments, but not anything beyond that.
Okay. Thank you. Doctor, can you speak to anything related to how we can better coordinate that type of information getting to providers, or even the sort of consultation that you might have with providers about baby's care and treatment after delivery?
Well, in Trisha's case, the NICU is qualified as a center magnet for about 20 different counties when they have NAS and NOWS together, or struggling or anything. Where she was in the hospital that everybody gets sent to, but that's where she was because that's, where she was admitted. They usually have a good staff. The leader there has been doing neonatal intensive care for over 30 years, and he's well respected in our community. But that knowledge out to other, even like major healthcare system hospitals, as hospitals are acquired by other hospitals and they all begin taking the same names, they still don't know what's going on at this hospital. We need to offer them the chance for education, because something like the My Babies Project can consolidate and concentrate what these places need. And let's forget about the medical part sometimes. The community mental health organizations and the other providers in the state, one of the biggest problems we have in addiction medicine, and it's, my confession, is we all don't speak with one voice. There's too many opinions. And I mean, we say what we think, and it's different here. It's different in Kent County. It's different down in Livingston or Washtenaw. Everybody is a little different. So I don't know if speaking with one voice is the right thing, because we need some regionalization, but we need some guidelines so that if we're going to reach out and help teach the labor and delivery clinics and the intensive neonatal intensive cares. I mean, there's hospitals that don't have neonatal intensive cares, and they try to manage the withdrawal symptoms. Now I kind of know where Trish was on her pregnancy, where they were asking these questions, and that's the center for where she was living at that time. But those are the kind of things that you talk to the mother about. The standard of babies in withdrawal is morphine in a milligram per kilogram ratio, and then a certain 10% reduction every 72 hours. If you can give that as a cartoon or a handout early on, and then you talk to the mother and say, I know you don't want your baby to have any drugs, but here's the reason why we need to do this, and that you educate the hospital staffs, if they choose not to ship the babies to a neonatal center. A baby in withdrawal will not feed, will dehydrate, and will lose weight. Those are three things we don't want in newborns. So the trigger to pull to begin treatment is dehydration, not feeding, and losing weight. And you cannot argue with that medically. So we really need to, and that's how we educate parents, to say, look, I know you don't want your child to have an opiate, but treating with this opiate increases feeding, decreases dehydration, and assures that your baby will gain weight. And there's nobody that would argue with that, but that has to be explained.
Thank you. So final question for you about how you prepare for that higher risk of overdose in the 4th trimester or postpartum. Dr. Maroney, how do you help to prepare for that?
I think the main issue is contact. You can't let patients go away, have babies, and then trust them to come back and see you if they have a problem. You need to see that person. You need to talk to that contact. You need to reach out and touch them and see that you make them proud. They bring you a baby in a car carrier and they want to show you, these cute little outfits. Contact. Giving that birth and all that time and investment and emotional value that they can share. I mean, they'll come to you and they'll show you pictures from the hospital, and sometimes they send you pictures in the hospital room. How we prepare people for that high risk is to lower the risk by increasing the information shared. In many cases, in substance use disorder, we have different technical statuses. Like a peer recovery coach can go out with somebody and have a cup of coffee, piece of pie, or a hamburger and talk about how stressful the day is. You would never do that with your addictionologist. You don't do that, okay? But a rare exception is the sharing of the birth of a baby that you helped. So recognizing that's important, and then the monitoring in the increased contact. You would also decrease the time between visits. If I was seeing somebody like Trish and she had a baby, and prior to her delivery, we were in touch once a month. After that delivery, I'd like to see her once a week for the first 30 days. And then twice a month thereafter, until I knew how stable and supportive her relationships were and her environment, and then she didn't have any hostile factors. Increasing exposure, contact, and decreasing the time between you see people. And that's not just your doctor, that's your therapist too. In some cases, we have special groups that are grant funded called Women's Specialty. Women's Specialty would take every single person that you had that went to the hospital and delivered a baby and put them on a list and go to their house and see them there. So you increase contact through media, you increase contact by decreasing the time to actually see the patient, and you increase contact by sending somebody to follow up in the environment. Because you have to know what kind of environment is. Whatever Trish says to me, if somebody goes to her house and comes back, they're going to tell me what's really going on. And when it's the same thing, that's copacetic.
Wonderful. Thank you so much for that. And Tricia, finally, what postpartum supports were most helpful to you?
Yes, doctor, my recovery doctor, my counselor. I wanted to say that the breastfeeding, the nurses who supported breastfeeding, they did a phenomenal job. They were absolutely amazing at showing you what to do, how to do, why to breastfeed, the benefits of it. They were extremely supportive in that area. And I do believe that attributed to my child's both my children, to their wonderful health today. I did want to say that I know due to COVID, it has been limited to only being able to have one person with you when you give birth. And it has to be the same person. I was wanting to exchange my husband for my pastor's wife. That couldn't happen. It had to be just one person. That was the same way with NICU going to see the baby. Now, my husband had never had a child before, with this in reference to my fourth pregnancy. Never had a child before. So this time around, with it being COVID, sending him downstairs, sending him upstairs to go to NICU. I think it would have been really helpful to have support that would have been able to speak to us together as a family, like family uniting, or even just to kind of guide the dads and show them how to pick the baby up, how to change a diaper, what to do. That hindered my husband from going to see the baby at all. So he did not see the baby until we were ready to take her home. And because of that, I had a lot of bonding issues that I think could have been prevented with better father support in the hospital as well. But yes, postpartum depression was something that I experienced in my fourth pregnancy. I was very quiet about it. I never had postpartum depression. I did not know what to expect. I was having crazy thoughts. Once again, I was on the Vivitrol shot and they were holding me for 5 days. And so I definitely was not going to tell them that I was having these thoughts because I already thought I was going to take my baby home. Being able to have a doctor that I could go to and outside of the hospital and telling him how I'm feeling or what kind of thoughts that I'm having a counselor that I was able to tell her exactly what I was thinking and know that she wasn't going to call a psych ward, she wasn't going to call CPS. I cannot tell you how big of a relief it is to be able to be honest when being in recovery. They say secrets keep you sick. Not being able to discuss the things that I need to be able to discuss, or that we in recovery need to be able to discuss, hinders a lot of our growth, and it's a barrier to growing in recovery. So yeah, I kind of got off track there, but yes, your original question, the breastfeeding support afterwards was awesome, along with my counselor and my recovery doctor. They were absolutely amazing.
Not off track at all. You shared some outstanding information and taught us all so much about how we can improve how we interact with pregnant patients and postpartum patients and their children. And I think this has been really an incredible opportunity to have a frank and open discussion about places we're doing so well and opportunities we have for improvement. And so I want to thank both of you first and foremost for your willingness to share and present. And I want to offer a last opportunity for our folks who've joined us to ask any questions you might have by using that question and answer feature in the bottom. So if folks have any questions, feel free to type those in. We'll give folks a second to do that. Do either of you have any last thoughts you'd like to share with us?
I'm going to let Trish go first.
I was going to let Dr. Maroney go first. I just want to thank you very much for the opportunity to be able to be here. Being on this side of the fence is an incredible opportunity. I really appreciate the opportunities to be able to grow. Thank you for this. I appreciate it a lot.
Thank you.
It's relieving to know that it is such a blessing to be able to help what was once the darkest nightmare in my life and in my recovery, to be able to use that to help women or to help anybody. It's priceless. So thank you.
Thank you. And your lived experience is there's no replacement for that. And we're just so grateful that you were willing to do this with us today. So thank you so much, Tricia. Dr. Maroney, do you have any last thoughts? Pearls of wisdom?
I want to thank Trish for offering a chance. Intimacy and vulnerability go hand in hand. And because you became vulnerable, we can get to know you. And that is a deepening tool in the sincerity in your recovery. Those are the tools other people are missing to grow. And I really appreciate you for everything you shared today. You did a great job. I would like to say that opportunities like this conference today and the whole My Baby's grant are outstanding opportunities as incubators to move people and to change thoughts. We need to reach out to each other and meet in places or invite each other to each other's counties and talk about some of these issues, because we know what the data and the statistics are that go through Michigan Department of Health and Human Services. But those are the people we need to move to. One of the biggest things that you learn from the past about where we might be able to go in the future, and one of the areas that I continually see the federal and the state government missing, we brought up the fact that we need more providers and that there's not enough providers by identifying counties where there's increased neonatal abstinence and there aren't any providers. That is always going to be with us. That is a terrible problem, and it's never really going to be fixed fast. But at a federal and a state level, the answer seems to always be to train more providers to get them there. Well, there's two models outside of that I'd like to plant seeds for the incubator. And COVID brought one of them to us as a silver lining in a dark cloud, and it's media. We can get into counties that don't have providers because now we have tools. This is an outstanding tool, but the barrier to this tool is policy. The policy that says a provider like myself still cannot see more than 275 patients. And that's what's keeping people away, is that there's policy that really scares providers to come and teach. There's policy that scares providers to come and care for somebody like Trish. Until we make the policy more flexible, one of the most insane definitions is that as a pain provider or primary care provider, I have an unlimited number of patients that I can prescribe Norco-Vicodin and OxyContin to, unlimited to give the prescriptions. But when it comes to treating people, like Trish and everybody else, they've capped me at 275. Now, this is not a Bill Maroney commercial. It's a commercial for changing the way we think about how do we get more providers. We can have maybe something like super users or centers of excellence where the providers that have the resources can see more than these false ceilings that have been imposed upon us. And if you really want to get people fast care when they're pregnant, you have to look at the barriers that are holding people back. To train people is one thing, to train people and to get them experience in SUD when there's pregnancy is an issue in perinatal, that's another thing. But it's almost like flipping a switch overnight. If you took somebody that's kind of doing it right and is got the resources, and they could go from 275 patient to a 500 or 600 patient limit, you have the providers you need. You don't have the policy you need. And you are the incubator for ideas in the future.
Thank you. Yes. And I think that's really an important outcome of this type of collaborative work and this type of learning environment. And I deeply appreciate that as a seed as we go forward. So I want to again thank Dr. Maroney and Tricia for your participation in the panel today. We now have an opportunity to learn a bit more about resources that are available to our community and folks who are pregnant or have a child with substance exposure. So I'm going to turn it over to Kim again, and she's going to speak to us along with some other panel members about resources. So Kim.
Thanks, Trish. So the objective for our resource part of the conference is to help you all be able to identify resources for the people that you're supporting who are pregnant and living with substance use disorders. So I'm going to begin by going over several different resources that are statewide available throughout the state. And then I have a few presenters from different agencies around in Michigan that will be presenting on resources that they have specific to their area. In January 2014, Michigan developed 10 prepaid inpatient health plans. These prepaid inpatient health plans are responsible for managing the Medicaid resources for behavioral health and intellectual or developmental disability services for Medicaid and Healthy Michigan enrollees. So they contract with community mental health agencies across the state in each of their regions to provide mental health services and services for people with developmental and intellectual disabilities. However, they also contract with organizations across the state to provide services for people who are living with substance use disorder. Someone may contact the access line for the prepaid inpatient health plan in the region in which you're serving, and help can be received. So if someone you know is seeking care for inpatient or outpatient services, you're going to receive a handout with the evaluation information after the conference that will have all of the PIHPs listed for the state of Michigan, as well as the counties they serve and their access number, so that you are able to contact them to help get someone in services for substance use disorders. They can connect you to services like detox services, inpatient substance use disorder services, such as residential treatment, or outpatient substance use disorder services. And so they also can connect you with, Dr. Maroney spoke of women's specialty services. They can connect you with those services as well. And so you will get that contact information following the presentation with the evaluation information. So next I want to talk with you about the community mental health agencies across Michigan. So community mental health service providers act as a single point of entry into the public mental health system, and they manage mental health benefits for persons who are enrolled in Medicaid, My Child, and the Adult Benefit Waiver. They provide comprehensive range of services to adults, to children, to adolescents, with mental illness, developmental disabilities, as well as substance use disorders. Community mental health service providers also provide a 24/7 crisis line that's free for anyone in the area to use. And that is across all of Michigan. So again, you're going to receive a handout with all of the community mental health agencies throughout Michigan, as well as all of the contact information to access services. The phone number that's going to be provided is going to be the access number to get someone into services. I want to let you know that with Community Mental Health Access Department, it's a no wrong door policy. So if you have someone who has, let's say, private insurance through Blue Cross Blue Shield, and they are in need of mental health services, but you have no idea where to send them, and they called the number on the back of their card and it didn't help them, they can contact the Access Department for their community mental health, and the community mental health will be able to help them find appropriate services in their county that can help them. So one resource that they provide, that community mental health provide, that I wanted to focus on and I thought was maybe important is the infant mental health program. So the infant mental health program provides home visits to families who are pregnant or within the infant's first 5 years of life. An infant mental health specialist will provide home visits and addresses the needs of the infant and other younger children in the family, as well as the mental health needs of the mother. Infant mental health services provide services which maximize the social, emotional, physical, and cognitive development of the infant and the toddler. They work on nurturing the attachment between the parent and the child, because that's a key component of their program. As we know, that's a key component of health for the dyad. Infant mental health services include things like individual and family therapy, case management, education on child development, some parenting strategies and strategies to help handle common childhood problems that the parents may experience, as well as help them to access a psychiatrist if necessary for medication to treat mental health services. We know that when the infant mental health services are utilized, there is a reduction in incidences and prevalence of abuse, neglect, developmental delay, as well as behavioral and emotional disorders. And so in order to access these infant mental health services through the community mental health agencies, you can utilize the number that you'll be provided with. Another program that I wanted to talk with you about is the maternal infant health program. Maternal infant health services are designed to help support pregnancy and infant health in the Medicaid population. So all pregnant and infant Medicaid patients are eligible for the service. Maternal infant health services, they use a registered nurse and licensed social worker to help pregnant people connect with doctors and health plans, help them access other services and other providers that are available in the areas in which they live. And the patient's seen through home visits during pregnancy, and then for a period after the child is born. And during these visits, there's an individualized plan of care that's developed by a team, and the teams usually are comprised of the registered nurse, the social worker, and then they may pull in a dietitian, lactation consultant, they may pull in infant mental health specialists from infant mental health programs, and they all work together to help come up with the patient, help come up with an individualized plan. And in the follow-up email that I've been talking about, you will receive a list of all of the maternal infant health programs in Michigan, as well as the contact information to get enrolled in services through them as well. So early on is the next program that I want to talk about, and they are Michigan's system for helping infants and toddlers ages birth to 3 and their families who have developmental delays or who are at risk for delays due to certain health conditions. So the program is designed to help families find the social, health, and educational services in their community that will help to promote the development of their infants and toddlers with special needs. the early on providers work really closely with the parent to help use everyday activities that the parent may go through to help encourage the development in whatever areas the child is lacking. And so they are they're very focused on having the parent do the, working with the parent to ensure that the parent is actively engaged in the treatment. And so an infant or child may be deemed to have a developmental delay if he or she is taking a little longer to learn some basic skills like feeding and dressing. Those are some self-help skills, or some cognitive skills like thinking, learning, reasoning abilities, communication skills like talking, listening, understanding, and physical development. So things like, their vision development, their hearing, their movement, their health, and then as well as social emotional development, like children having difficult time with feelings, with getting along with others, or developing relationships. And so referrals for early on are able to be made online, over the phone, or through the email. And you will be provided with early on service provider contact form linked with the email for the evaluation, just like everything else. So at this time, I would like to turn it over to Rich Van Tol from the Bay Aranac ISD to talk with us about Great Start and the wonderful resources that Bay and Aranac counties have to offer through their program. Rich.
Great, thank you, Kimberly. So Rich Van Tol, I'm with the Bay Aranac Intermediate School District, and I wear a couple different hats. I'm the Great Start Collaborative Director, as well as Starting Strong Supervisor, and I also do some work on some other projects as well. So thank you for the invitation. Thank you for letting me just provide just a few bits of information and resources. So with our Great Start efforts, we're really targeting and aiming a lot of our programming and services towards families with young children. So prenatally up to age 5 is sort of our target population, and really want to support families in really 5 different areas, 5 key areas. And so, and when I say support them, usually it's some of it can be referrals, so just supporting families with knowledge and information and where to go, where to turn, who to turn to for information, and also partner collaboration. So we do a lot with convening collaborative partners to work together collectively to have an impact on family outcomes here in Bay and Aranac counties. And so the 5 key areas, the first one is really important, social emotional health. And so we don't actually provide a lot of direct service in the area of social emotional health, but it is such a priority and area of emphasis that we collaborate with organizations. A lot of you are on this call, I assume. So anybody that provides mental health resources or substance use resources and supports in the community, whether they be large formal organizations or small informal groups, we want to connect families to those organizations, to those groups, so they have supports along social emotional health. And we provide a lot of education and awareness and partnership opportunities to refer families for programs that can support them in that domain. The other is early childhood education, so childcare and preschool. And so we have, and I'm going to rattle off a few websites and reference a few links. One of them is bayaranacpreschool.org. So if folks go to www.bayaranacpreschool.org, what they'll find and what we've created is essentially a one-stop hub for any family that's looking for home visiting services and or preschool programs. Some of them have qualifying conditions, and so like MIHP and early on and Starting Strong, Early Head Start, those are home visiting programs or home-based programs that serve families with either prenatally and or infants and toddlers in our community. And so I would go to bayaranacpreschool.com or .org. I think you can use any one of those interchangeably for more information on that. The other one is Great Start to Quality. So if families are looking for high quality childcare, they can do either a quick Google search or put in greatstarttoquality.com, and they'll find, again, a repository and a list of resources on where to find high quality childcare, accessible, affordable, high quality childcare. There's even a number to call too. So for both those, for Bay Area Neck Preschool and for Great Start to Quality, if individuals maybe they don't have internet access or don't have ready available internet, there's numbers to call for each of those, and I can send this out to all the participants subsequent to this discussion today. So childcare and preschool are two really important pieces of the 5 pieces. Parent leadership. So we have a Great Start Collaborative Parent Coalition. It's a grassroots coalition of parents. And what's amazing about this is these parents, they're afforded opportunities to network, share information, and kids don't come when they're born. They don't come with instructions, and oftentimes some families just might not trust more formal institutions and organizations, and so oftentimes the trusted messenger is another parent, another family that's having similar experiences. And so we try to create opportunities for parents to network. They build rapport. They become essentially a support group for one another, and they provide referrals to each other and share information about programs and services sort of organically during those networking opportunities. And so that's all part of our Great Start Collaborative Parent Coalition. And if you know families that have young children and are interested in that, obviously they can reach out to myself, and I can we can get them a part of our parent coalition. That was the third. The fourth is family support. So we know basic needs are really important. Of course, Maslow's hierarchy of needs. If families don't have adequate housing or food or water or shelter, or just access to basic medical and mental health and oral health resources, that's really important. So we try to connect families to organizations and also 211, for example, which is sort of like an umbrella resource and referral organization that we connect families to so they can get access to basic needs supports and resources. And then last but not least, and I think particularly relevant here is pediatric and family health. So we want all families who are expecting or have young children to have healthcare insurance. So whether they're getting that through a private situation or a public situation, whether it's Medicaid or whether it's through a private insurance, make sure they have insurance, make sure they have a medical home, make sure they have an oral health care home, and that they are keeping up to date on those medical appointments, and they're aware of the importance of those ongoing screenings in terms of surveillance of their child's progress relative to their age and the stages of child development in all domains, whether it be hearing or vision or social emotional learning or cognitive health or regular healthcare services as well. So that's really important. And I have to stress that this is all done in collaboration with other partners. I mean, we collaborate with like our health department. I know particular to this substance use issue, we collaborate very closely with Bay County Prevention Network, Neighborhood Resource Center, McLaren Bay Healthcare Systems, both our Bay County Health Department and Central District Health Department up in Aranac County. They are critical allies in this effort to do grassroots, community-based, place-based prevention work. And I use the word prevention very intentionally because much of what we do in the domain of Great Start is very much prevention oriented. So that's kind of just a quick overview of the Great Start Collaborative, the Great Start Collaborative system, the array of sort of supports and resources that we would have available. And then I'll just lastly mention, we do have a partnership initiative called Safe Journey. And I'll get the information out there. It's the information can be found at safejourneybaycity.weebly.com, and I'll make sure we get the website out. But this again is a collective impact type of model where we have multiple partners working together to spread the word about the importance of not using substances, alcohol and other substances, both before pregnancy, during pregnancy, and after pregnancy, and letting individuals know the importance of not using substances during their pregnancy, but also, just as importantly, if they are, where to turn for support to get help and mitigate any of the harmful effects that might occur during that pregnancy if they are using substances. So those were my comments, and I again appreciate all the work that everyone on this call is doing.
Thank you so much, Rich, for all of that information. So at this time, I would like to invite Tori Worth to talk with us about Northern Michigan Substance Abuse Services, Inc., and the wonderful resources that they have available.
Thank you so much, Kimberly. Appreciate the invite. Thank you. Good to see you again, Tricia. And it's an honor to be here with all of you. It's just awesome to hear Dr. Maroney and Tricia with recovery, and now she's a recovery coach. How inspiring! You know, it's just always love hearing about people, recovery, and then being able to give back. And that's one of the things that we've found to be true in recovery. Is a lot of folks, when they get in recovery, they want to be able to help others. And so that was kind of what started in our region in 2012. Was we had a group of individuals who were in recovery, and they asked, what is it that we need in our region? And we really needed some continuity. We needed people to be connected. We had folks leaving treatment downstate and coming up to rural Michigan and not having a lot of resources or connections to the recovery community. So they decided to offer a lot of education and training to be able to help folks in our own communities. So it's really kind of a community development capacity. I kind of missed my own intro. I'm Tori Worth. I'm the NIMSAS Recovery Supports Coordinator for NIMSAS Recovery Center up in Gaylord. I'm currently at home in Petoskey, and also a person in long-term recovery. So it's just an honor to be here today and talk about recovery and recovery support services. So that's what we do offer. We offer free recovery coach trainings for people in our region. I heard a lot of talk about stages of change and utilizing motivational interviewing skills. So when folks take the recovery coach training, they get to learn skills, multiple pathways of recovery, and trying to really utilize a strength-based approach when we're working with folks, whatever stage that they're at. And so we get a chance to really build on this pool or this network of people in recovery in Northern Michigan. So we have a few criteria where folks have to at least have 6 months of recovery to take the trainings. And then we also offer additional trainings like ethics trainings for folks to be able to know what ethical boundaries are for recovery coaches. And we offer recovery advocacy trainings and even recovery messaging training, which I know Tricia earlier on talked about stigma and a lot of times the words that we use. So we do a lot of free trainings to be able to help really, I think what Rich was just talking about was trying to bring people together so that way we can really share resources and network with each other. So that really happens kind of organically through people coming together in our region. And then we get a chance to share resources and really make the region a little bit smaller up here and bring folks together so we can work as a team and kind of unite. And I heard Dr. Maroney talk a lot about, kind of getting out of those silos in many ways. So a lot of the recovery coaches that we have, or all of the recovery coaches that we have, are volunteers, but many of them are getting jobs working for, Catholic Human Services in Alpena, Munson, and Traverse City, and folks at the health department. And so we have a lot of folks out there, and then we can share information together very, very quickly. So it's been a really amazing network and team of people in Northern Michigan being able to share those types of resources. So a couple other quick things too that I wanted to also let folks know. Besides the free training, we do have our upicrecovery.org website where folks can learn about lots of different resources. We offer a couple virtual things in virtual connections. So when COVID started, of course, we had to figure out how do we stay connected and reach folks. So we've started a virtually inspired recovery series. So every Tuesday, Wednesday, and Thursday from 12 to 1, we have a way for folks to be able to connect with us. Tuesdays and Thursdays is a recovery hour where we just have open discussion. So we have folks from the UP, we have folks from downstate and folks from out of state that have joined us. But it's just an opportunity for us to talk. It's not a meeting. It's just an opportunity for us to share resources and talk about whatever's going on. And then on Wednesdays from 12 to 1, we always have a speaker somewhere from somebody that's either local or state or national that will come on and share resources. So it's kind of been a great way for us to really reach outside of our kind of bubble up here and get to know what other resources are going on in other places. And it's open for anybody. We have all that information on our upicrecovery.org website, as well as we have a Facebook page called NIMSAS Peer Recovery Support Services that folks are welcome to join and like. We always put our upcoming opportunities up there as well. And then we have it's a recovery coach check-in, a bi-monthly recovery coach check-in from Tuesdays. It's every other Tuesday, starting this Tuesday from 3 to 4. We've been doing that for quite a while now, actually. But it's kind of anybody that's working with people that within recovery, it's an opportunity for us to really kind of sharpen our tools, connect with each other, talk about what's going on. Sometimes we'll bring in a speaker to kind of talk really briefly about some of their resources, but then it's just an opportunity for us to share what are you seeing? You know, what are folks seeing right now? And of course, right now there's some pretty big struggles with other substances, so it's been a challenge. So we really want to make sure that we can try to stay together as best as we can. So if anybody's interested in that, you're welcome to check out our website as well as our Facebook page as well. So that is kind of it in a nutshell, but we really believe that recovery inspires recovery. So when I see folks like Tricia that's out there and helping others, we just know that has a ripple effect, and then hopefully we can bring other folks and they want to get on board and do the same thing. So it's a beautiful, beautiful thing. So I really appreciate being a part of this today, and thank you all for the great information.
Thank you so much. So now Tricia Longley is going to talk with us a little bit about Peer 360 and the wonderful things they have going on.
Hello. Yes, so mine's going to sound pretty similar to Tori's. I realize that we have a lot in common there. So Peer 360, we are a diverse community. We help to remove barriers that hinder people from success and from growth in the recovery. We serve as a bridge between the recovery community and the medical professionalism. We help bring awareness to our community. We help to reduce stigma. What I did want to speak about is that we have, love Peer 360, thank you very much. We have meetings 7 days a week. We have Recovery on the Nines is a program that we have 9 a.m. and 9 p.m. 7 days a week. You can find a Peer 360 recovery meeting online via Zoom. And 12 and 6, we have meetings as well. So 9 a.m., 12 p.m., 6 p.m., and 9 p.m., 7 days a week. We have meetings that can be accessed, once again, via Zoom. And for more information on that, you can go to www.peer360recovery.org. And we also do trainings. We train people. We do a Recovery Coach Academy, a CCAR Academy. We do motivational interviewing. We do ethics training, Recovery 101, boundary and professionalism. And so once again, it's just helping teach people the tools that they need to continue to be successful in life. And upon set aside from our 4 meetings 7 days a week, we have a women's recovery meeting that takes place every Friday at 3 o'clock. That is a women's recovery meeting. And we also have a veterans meeting, which is designed specifically and only for veterans. I believe that is Tuesday. I know it's on Tuesdays, 6 or 7 o'clock, but once again, the information can be found at the bottom. We do have some events that are coming up. So at Peer 360, we have went hand in hand with the Native American tribal community, and there is an event this Saturday, August 21st. They're going to be getting together Nelson Park on Broadway Street. It's going to be happening in Mount Pleasant. They're going to be going tubing and doing a whole bunch of fun stuff. So you're going to want to come check that out. Fridays, actually right here where I'm at in Recovery Pathways, every Friday at 12 o'clock, we have an in-person recovery meeting that happens every Friday here. I'm sorry, I'm not sure if I was allowed to say my location.
You're fine. You're good. Okay. No, you are good.
Okay, so I'm sorry about that. But no, anyways,
you're good.
Okay, thank you. Fridays at 12 o'clock at Peer 360, Peer 360 meeting at Recovery Pathways, in-person meeting. Also Thursdays as well, we have in-person meetings. Those take place at 4 p.m. on Thursdays at 503 North Euclid Avenue, Suite 7. Also coming up, we have a game night. So once again, during COVID, just like how Tori was saying, we too are trying to find ways of entertainment and helping provide a safe atmosphere for people who wanted to have fun in recovery. So with yours truly, I will be hosting Saturday, September 4th. I'll be hosting a game night along with another one of my friends from recovery. His name is David. Anyways, it's going to be Saturday, September 4th at 6 p.m. And the meeting ID code is right there on the flyer. If you look at the top right-hand corner, it'll say game night. Just below that is the passcode. So that is a way to be able to access our Zoom game nights. And they're pretty fun, you guys. We're going to be doing Pictionary. So Saturday, September 4th. And the information for our meetings can be found in the bottom right-hand corner of this slide. And once again, you can go to www.peer360recovery.org. And we also, we train recovery coaches. We train people to become recovery coaches. So if you know anyone who is in need of a recovery coach or seeking recovery coach services, please feel free to reach out. And we have, at our main location, we have a woman named Barbara, and she is just phenomenal. She's amazing at help connecting people to resources as well. So please feel free to contact Peer 360 Recovery. And that is what I have. Thank you.
Thanks, Trisha. So just so you all know, the flyers that are all here, we will be sending out as well with the follow-up email. So now we have Katrina Keogh. Did I say that right, Katrina? I'm sorry if I—
Oh, you did. You did great.
If I destroyed your last name. She's going to talk with us about the Upper Peninsula Maternal Opioid Misuse Model. So welcome, Katrina.
Thank you so much. As Kimberly mentioned, my name is Katrina. I'm the project director with Upper Peninsula Healthcare Solutions, which is a nonprofit sister company to a managed care organization that offers Medicaid and Medicare called Upper Peninsula Health Plan. And together we are Region 1 of the Perinatal Quality Collaborative. And I just want to lift up some of the comments that Trish and Dr. Maroney provided in that need for connectedness of providers and services of this population. This is exactly why the UP maternal opioid misuse model exists. The model is a grant that was awarded via HRSA care coordination from the Federal Office of Rural Health Policy in the spring of 2019 as a result of the Maternal Infant Health and Equity Improvement Plan at the state, and is also supported by MDHHS. And Region 1, or the Upper Peninsula, specifically is implementing and expanding a universal referral and screening tool for SUD, expanding to evidence-based home services like that of MIHP, and then of course enhancing the continuum of care for all birthing peoples across providers and community-based services by addressing social determinants of health, and then of course removing those barriers and increasing access and utilization services with a community health worker. So the care coordination efforts using that community health worker model have really seen some significant impacts in the reduction of NAS births by using a multifaceted approach. Thank you, perfect. So these approaches begin with identification and an appropriate referral process, and for a coordinated response to be activated by a dedicated healthcare team, which includes a social worker, a nurse, and the community health worker. And then they utilize, they get individuals referred to them using this universal referral form. So when we're talking about the ability for providers to know what programs to refer their individuals to for certain needs, in more often than not in the Upper Peninsula, we've had providers say, why would I screen them for anything when I don't know where to refer them or there isn't a program to refer them to? So we use this universal screening referral form for our target population, but also for all pregnant individuals in the Upper Peninsula. And once this form is completed with the individual, with the birthing person, then it is faxed to the hub where that birthing person either lives, assuming that they have stable housing, and or is receiving the most of their care. So when they're indicating that they have some sort of experience or past history with opioid use disorder, UP Mom provides them with a support system for those needs. My dog's barking, sorry. that are difficult to navigate, like their transportation, accessing insurance, completing housing applications, which sometimes includes getting some sort of birth certificate or other identification that they don't have and is not provided at the hospital when their infants are born. And then any other services are eligible for by supporting and enhancing that existing home visiting model through the maternal infant health program. So it also works to solve that concern the providers have when they see that patient, but then is unsure of that success of the referral or closing that referral loop when that individual needs assistance when they've actually identified them. And as Dr. Maroney alluded to, it also allows for an extra set of eyes to follow the birthing person and their infant or their family upon discharge from residential treatment, continued outpatient treatment, the NICU, or the family birthing center, in order to continue to ensure that both have a healthy and thriving relationship. And so we've seen a lot of different successes through this. If we can go to the next slide, please. Thank you. To touch on who our birthing individuals are, they're pregnant and women who are postpartum or under 12 months postpartum since September 1, which is when the project began. They are either active or have a history of experiencing opioid use disorder. This can be identified through claims, through insurance providers, simple word of mouth referrals, or a self-identified experience with opioid use disorder. And by meeting their basic needs, as a lot of these other programs do, and providing solutions like housing, transportation, and what have you, we're seeing an overall reduced number for those who don't have a dental home, don't have a PCP, aren't accessing these regularly within the past 12 months. And for those that have been enrolled in UP Mom, compared to the population that was not enrolled in UP Mom for the same target cohort, we're seeing that enhanced access and improved timeliness of prenatal care. And then we're also seeing that we are reducing the average length of stay in the neonatal intensive care unit. And we're also seeing this utilizing Eat, Sleep, Console versus the Finnegan scoring. And we're also seeing this with a rooming in program. And this is very active in Chippewa County up in the War Memorial Health system and hospital. And so we are now looking in year 2 to expand to Chippewa. And then year 3, we're looking to replicate the model and consult other organizations who want to implement this model. We also have a website on the next slide there. Thank you. New website, a Facebook page. The website also includes information on our Perinatal Collaborative and the multiple coordinated efforts at assisting individuals who are experiencing any sort of substance use disorder, those who may be interested in utilizing the services of the Universal Referral Form, or any other questions that you might have.
Thank you so much, Katrina. So now I am going to go on to talk about just a couple more Michigan resources. So Katrina actually kind of segued me into this. So Michigan has divided the state into 10 regions, and the 10 regions have their perinatal quality collaboratives. And the perinatal quality collaboratives are the key drivers of what Tricia mentioned, the Mother-Infant Health and Equity Improvement Plan, which integrated interventions across the maternal-infant dyad, promoting a holistic approach to care that encompasses the health and well-being for both mom and baby. And building off years of successful work across Michigan and addressing the gaps which have persistently left behind the most vulnerable groups of women and infants across our state. So they're very important in our communities and do a significant amount of work. There are 6 areas that these perinatal quality collaboratives work on. And those 6 areas are health equity, healthy girls, women and mothers, optimal birthing space, full-term healthy weight babies, having infants sleep safely, as well as maternal, emotional, and behavioral well-being. And so they each have plans to help address these issues. These quality collaboratives are made up from professionals as well as community members who hold an interest in perinatal outcomes. If you're interested in getting involved, when I send out the follow-up email with the evaluation information, you will also receive a list of all of the perinatal quality collaboratives in Michigan, as well as their coordinators, and how to contact them. So the last slide is just a list of some recovery groups that are available Michigan-wide, as well as ways to find meetings that may be a little more local to your area. When Tori and Trisha were talking, they had talked about how they had to, start doing online things due to COVID-19. And like Tori and Trisha, a lot of these services have gone to online as well. However, they are starting to come back to in-person meetings. So these are available for you to go ahead and utilize if you have patients that you are seeing who are in need of resources such as Alcoholics Anonymous, Narcotics Anonymous, Cocaine Anonymous, Marijuana Anonymous, Celebrate Recovery, and Smart Recovery. I know that at least Tori had a couple of these on his slide, and so they're available throughout Michigan. So these are some ways in which you can access them. These are the resources that I used to help develop some of the slides that I presented. And then I want to take some time to thank Rich and Tori and Trisha Longley and Katrina for sharing all of the awesome resources that you guys provided to us. I wanted to open it up for any questions pertaining to resources that you may have today. So you can use the Q&A part in the bottom of your screen and type any questions in that area.
Kim, we did have a question during the presentation, and I think it got answered in the chat, but I wanted to bring it up so everyone else can benefit from this as well. There was a question related to whether individuals who are still in active use can engage in the recovery support activities that Tori and Trisha spoke of. And they indicated, yes, absolutely. They meet folks where they're at and they provide help as they can. So, and guidance and resources and so on. So wanted to share that.
Thank you. I'll just give it a minute in case anyone has any questions and answers or any questions. Okay, it doesn't look like it. So I just want to thank you all very much for attending the conference. We'd like to ensure that we complete the conference on time so we can respect your time. I just want to remind everyone that we will be providing certificates at the completion of the evaluations for the conference for your convenience, as long as you do two things. Thing number one, sign in via the chat with your name, your credentials, and your email address. And then when you get the evaluation following the conference, it will probably be Monday, you go ahead and complete the evaluation for your continuing educations that you're asking for. We are offering continuing medical education credits thanks to Mid-Michigan Health. We are offering social work credits thanks to Saginaw Valley State University, and we are offering substance use disorder credits thanks to Mid-State Health Network. So we just want to take some time to thank all of our amazing presenters for their time and expertise. And we hope you all enjoy the rest of your Friday and have an amazing weekend. Thanks again.
Bye. Thank you for this opportunity.